north of Denver, Colorado. So please start.
Thank you. First of all, I want to thank everyone who presented before me. That really lays the groundwork for this presentation, and I can move a little bit quicker then, since people have a good understanding of a lot of the anatomy and some of the finite element modeling. And this is presentation is based on our work with a company called Exponent. Mostly there are engineers who work on solving difficult problems, and they created a finite element model for us for the SI joint going back almost a decade ago, when we started looking at trying to develop instrumentation and fusion devices for the sacroiliac joint, and we wanted to have something to guide us. So this is where that started, and I'd like to recognize them as well as my collaborators. And I'll just move forward and give my disclosures. Yes, I do have ownership interest in a company, but we do not have a device that is cleared as of yet, but we're using Exponent and their expertise, as well as some other engineers to guide us in that direction. So I'd like to recognize them. And specifically the device we were looking at based on working with the FDA and recognizing the regulatory hurdles when you're creating an implant versus an allograft, which people may not know. In Europe or in Japan, it has a different regulatory pathway. You basically just have to show that it's not transmitting diseases. That's the major issue they look for in an allograft, not necessarily proving it has any specific characteristics in terms of treating the problem versus an implant. It's a much more rigorous process. So before going into cadaveric studies and clinical trials, it made a lot of sense to have a finite element model where you can do an analysis of your implants. And I think this is going to be true for all the implants out there. I think there's probably 50 companies now with different implants. So coming up with a FEM we can all agree to would be very helpful. This one specifically is a design we call the X device, and it has features that have engagement of the sacrum and the ilium on either side for stability, as well as a bone window. And we can also add a screw to make it a hybrid, which sometimes is advantageous depending on the problem you're treating, what kind of curvy road you're treating or a straight road, the type of biomechanics, if the patient's heavy, if they have dense bone, if they have prior fusions, if they've had trauma, more instability, you need to be able to pivot. So those are the things we were looking at. So these are the kind of the basic shapes, and the bone window you can see is very generous. The screw is self-harvesting and can be added across the joint as well for extra stability. And what we're using primarily is what we call the posterior inferior approach. Dr. Raji, I think, was describing that. And in addition to that, you can see you can add a screw for additional stabilization. So just to make sure everybody understands, the posterior inferior approach is what I'm describing is above the sciatic notch and just below the PSIS. And this is where the articular cartilage can be easily accessed. You can see the cartilage or the articular cartilage portion of the joint is auricular or L-shaped, and it has the two areas that Dr. Raji was pointing out as opportunities. So with that, the one that we tend to prefer because of ease of access and the anatomy and safety is the posterior inferior placement above the sciatic notch, and basically follows a simple process of a drill followed by the broach and then the implant and placed in this position. It can be done standalone or by itself, or you can add the screw as we show in this illustration. And why the posterior inferior approach? Well, we believe this is the most ideal place, and I've been performing SI joint fusions for over 30 years, and I did several different techniques, anterior, lateral, Smith-Peterson. I tried a lot of things, and I found following basic orthopedic principles, just approaching the joint like Dr. Cross was talking about, an ankle or subtalar joint, to the joint cartilage to be able to remove that and apply orthopedic principles. So with the posterior inferior approach, there's minimal soft tissue dissection. You do have a lot of safety features around the anatomy. There's always anatomy that could get in trouble, but try to minimize that by the approach. Then you remove the cartilage and then perform bone fusion types of procedures by decorticating, but leaving the dense bone as much as you can, and then finding the fixation that allows you the best fixation fusion without having to add additional features or extra screws if possible. This is what it looks like. You know, the lateral approach on the right side, you can see we're going through a lot of anatomy and also the vascular structures and the neurovascular structures on the other side of the sacrum in the pelvic area. And the posterior area is a smaller area, very devoid of most tissues, but obviously you're going through skin, subcutaneous tissue, muscle, some aponeurosis, and a very small, thin capsule at this portion of the joint. Of course, the lateral side has been described, and there's a lot of anatomy that could get you in trouble, and that's been well outlined in a lot of studies and the way the FDA follows the implant logs. Again, with this approach, we're looking for the articular portion, the yellow tinted area of this description of the joint. It can be either placed straight down the posterior arm, or you could take it obliquely too. Like Dr. Raji was saying, you know, for females, maybe you want the implant more in the anterior portion. You can reach that fairly easily, as you can see, just by changing the angulation of the device. And why the posterior inferior in terms of the anatomy, in addition to the neurovascular structures, you can see it's a very narrow space. It's maybe 1 to 2 millimeters. The cartilage peels off most of the time like the skin of an orange. If you go in the extra-articular portion of the ligaments, those ligaments, there's a huge gap. You can see some of the diana sizes go from 13 to 19. And you're also having to remove the ligaments that are actually attached into the bone, which interfere with bony integration versus the compressive forces anteriorly against the dense bone. Some of the other implants that are placed in this extra-articular space, interesting enough, to come in typically one size and are about 8 millimeters, whereas the Diana has multiple sizes to fit that anatomy. So that has to be taken into consideration, as well as the density of the bone. Obviously, if you want to do fixation and fusion, you want to have good dense bone so it doesn't subside. And there's been studies that show that you do have high Hounsfield units in that region of the joint compared to the very hollow sacrum, typically outside of the articular portion of the joint. And I'd like to recognize all the people who've done the work on this, but I can't name them just for timing's sake, but very helpful. Bruce Dahl, though, yeah, he does deserve extra recognition for all the work he's done over his lifetime. So I will call it out. And I refer to his biomechanical study primarily because as we do this posterior inferior approach, people worry about, what are you destabilizing? Well, he kind of showed through this biomechanical study, cadaveric study, that you can remove almost all those posterior ligaments back there. And believe it or not, you really don't render the joint grossly unstable. We're certainly not advocating for that. I used to do that procedure and get good fixation and fusions, but with the minor disruption of the posterior inferior small capsule, I think it's safe to say we're not really disrupting the joint. So with this, we want to have this finite element model created. Exponent, the company I referenced, has a lot of experience in engineering, but they created this model for us. And without getting into all the details, I'm sure the engineers would like, but we used pretty traditional loading characteristics, as you can see, 10 Newton meters followed by a load of 400 Newtons. And then the idea was not only take a traditional male model and create this the geometry, place it into software that can reconstruct the model using material properties. I just want to make sure you understand they're well thought out, and I'm not going to get into the details, but you have to include not only the bone, but the ligaments, and then you have to validate it, which they did against the literature, and it showed it was valid. And then we're going to start placing the implants. And how you choose these really has to do with the anatomy that we discussed and how to get a good bony fusion in a safe place. So this is the directions that we chose, and you can do it with different implants and different positions. And I think that's one of the key factors is this presentation. It'd be great to have, you know, a FEM that we all agree on, and we can compare different devices and different types of situations and patients' body habitus, their bone density, the type of injuries they have, male or female. So with that, we looked at a lot of these different parameters. There are traditional. We can see that, you know, it was loaded at, you know, with 400 newtons, and the control they used initially is intact. In other words, this is the motion. The more red you see, as you can see by this displacement colors, the more movement is going to be red, the less movement is going to be blue. So this is the intact model. But what they also did was like, okay, for the FDA's sake and all of our sakes, hey, we went in there, we are very aggressive. We removed all the articular cartilage from the entire joint. And how would that look? Well, the way the engineers figured out to do that was actually take the model and separate the ilium away from the sacrum. The distance of the typical thickness of the articular cartilage, which is about 2.6 millimeters. And that simulates a very aggressive joint destabilization, decortication type of procedure. So in the worst case scenario, we started to look at that. And you can see, even compared to the intact, we see a significant decrease in motion when you add the implant by itself, which is in the middle. And then if you add the hybrid and go to the you know, more stable configuration that you may or may not need, depending on your specific patient characteristics. Again, there's the control, and that's the intact we're comparing to here. And I'm not going to spend a lot of time other than these are representing the maximum surface displacements. And you can see there's substantial decrease, more with the implants. Certainly the anchor can help depending on which specific loading and movement we're looking at. Again, without getting into a lot of details, there's a summary graph at the end, but you see a lot more of the blue color as you move to the right, where you have more fixation. And this is done in all different types of loading. And this shows, you know, the almost the instant center of rotation that we're talking about, that posterior inferior portion. And where you want to place your implants will be dependent on these characteristics. So let me get to the bottom line here to save some time. And what we found out is if you place the implant, which we call the X as described, you compare just the intact control. I mean, without the cartilage being removed, you still see significant decrease motion in terms of percentages. And then if you add the screw, you see you get additional motion in that mid portion of that table. If you actually then compare it to the destabilized control, you can see it's even dramatically more stable by adding the X implant by itself. And then obviously the screw will give you some extra advantage. And we've further validated that with a biomechanical cadaveric study. And this case, we used 880 newtons for 50,000 cycles. And we found that it was not significantly different by placing your predicate trauma screws, AO trauma screws on the other side. So that helped us confirm that we were going in the right direction before we went to the cadaveric study. Other people who are interested in this space, as Dr. Raji was pointing out, there's an intro device that's through SI bone, and they seem to prefer this posterior inferior approach as well, using a cortical triangular allograft. And what they did and used a FEM that's not publicly available. But what I found information on their website was comparison to a device placed in the extra-articular space, as you can see on the right-hand side. And what they did was they use their FEM and their analysis to simulate what's the difference in those different locations using those types of devices. And you can see with lateral bending, there's quite a substantial improvement, further validating the posterior inferior approach. Again, also with flexion extension, even more significant. And the rest of the motions that they describe. So this is kind of their summary. And without having the details of all of their, how they created their FEM, it's hard to fully extrapolate, but we can see this is the trend to use this modeling, which is going to be very helpful. And I think what this comes down to is this is a very powerful tool I think we can use to help choose the approach, the type of device, but we need to have the consensus so we're actually comparing apples to apples and obviously not other fruits, because that's not going to give us the answers at the end of the day. Thank you.
Jeff, thank you very much for this conclusion, and especially the vegetables. I love this picture. Discussion. So we're up to discussion for the last 5 talks. Any questions?
Martin?
Yes, Pascal.
Martin, I wrote a chat system. I wrote my questions to chat system. Would you check it? Because it is better for me to make sentence.
To the chat.
Chat. Yes, chat.
Yes. Yeah. Yes. Yes, we're in the chat. Yes. I do see the chats.